Okay, so we're looking at the knee joint today, looking at the knee. So this is a little bit more complicated than the calf, although it works fairly similarly. We're actually going to see some of our muscles from the calf show back up again. So we won't be putting those back in our notes just because you've already got them. We've already kind of covered them. But as we are looking at it, right, your knee joint greatly affected, greatly influenced by both of the joints above and below it, right? So when you look at your knee joint, you know, obviously if your ankle is malaligned, that's going to mess up your knee. But also if you have hip tightness, that's also going to mess up your knee. You know, it's your knee is sometimes stuck between a rock and a hard place, you know? And so we do know that there's a lot of structures that are there to allow your ankle and your hip joints and your knee joints to all work together. Your knee, because it's in the middle, and actually because it is the largest joint in your body, tends to be a little more complex than some of our other joints. So we're going to see some structures that are fairly unique to the knee compared to some of our other joints. And that's just because of how large it is and the fact that it needs to deal with like pretty extreme forces, you know. Your knee does take like a lot of the punishment of everyday lives. So it does primarily act as a hinge joint, but we're going to look at how there's a little bit of rotary motion there as well. So when we're talking about the epidemiology of knee injuries, right? Which is just like to say the common knee injuries that we tend to see. We're going to see about 80 to 100,000 ACL tears a year in the US alone, which is crazy, right? That's a lot of ACL tears, not to mention like all of the other types of knee injuries that we've got. But we do know that like a lot of times, most of these injuries tend to be like non-contact injuries. A lot of times ACL tears are typically associated with like planting and cutting motions. So that's a non-contact injury. That's, you know, basically where somebody maybe jukes this way, turns and tries to like accelerate and, you know, they end up tearing their ACL. So very, very, very common, but it really shouldn't be common, you know, like this is a fairly preventable injury that happens because the, you know, the structures inside the knee are weak or the structures around the knee are weak or, you know, tight. So approximately 70% of those are going to be non-contact injury. Most of them occur between the ages of 15 and 25 because that's when a lot of people are, you know, playing different types of athletic events and things like that, but still kind of struggling with like, you know, sedentary lifestyles and inactivity and things like that. And so how are we going to work on this? How do we like reduce the risk of ACL injuries? Well, a lot of research suggests that enhancing your stabilization, so your body's ability to control itself, may actually reduce the risk of those injuries. So a lot of balance training, a lot of core training, things like that. So one of the most common other knee injuries that we are going to see are also what are known as meniscus tears. So remember I said that your knee is fairly unique. Well, it's got these really cool little structures inside of them called your menisci, or, you know, your medial meniscus and your lateral meniscus. And they're these little C-shaped pieces of cartilage, basically, that sit on top of your tibia. So here's your shin, right? That's your tibia right there. And you can see the fibula off to the side, and there's your femur up top, kneecap kind of covering everything. Right on the top, you'll notice that your meniscus kind of sits there, and its job, the job of the meniscus is to kind of be thicker on the outside and thinner on the inside to create this kind of concave shape. And that way your femur can't really slide off of the top of that shin bone. It's not really going to go sliding around anywhere. So it's there, you know, to reduce friction and to provide some stability. And when we see like what is known as like a shear force, right? Shearing is basically when you're pushing and twisting simultaneously, that can sometimes cause tears here. And so you can see this one here. This is called a bucket handle tear. Basically, it kind of looks like the handle of a bucket, like you thread your fingers through there. And so that's like a common tear, or you're just going to see a classic tear like this. Both of those are meniscus tears. Generally, when somebody experiences this, it involves while they are either flexing or extending while doing like a lot of directional change. So again, kind of like a planting and cutting situation. So that's a really, really common injury there as well. Again, the way we prevent stuff like that is we do more stabilization training. There's the ACL right there, right? Your anterior cruciate. Oh, question? Yeah.
Yeah, sorry, Brad. Is a meniscus like just some fascia? Is that basically what it is?
No, it's kind of its own thing. It is connective tissue like fascia is, but it is meant to. It's more similar to cartilage than anything. Let me see here. I'll pull up a picture of a meniscus. Meniscus. This could get a little gross. I'm trying to pull up a real photo. Yeah, they're like, we don't want to put this on Google Images. Well, anyway, it is. You can see it's more similar to like ligaments or more similar to cartilage versus like fascia, which looks more like, you know, it's surrounding. It's the white connective tissue that kind of surrounds your muscles and holds your muscles in place. And like keeps them traveling. Oh, that's a great picture of fascia. Okay, you see this? It's kind of like the wrapper around the outside of your muscles. That's really what fascia is there for, versus like your meniscus, which is just there to like act as like a little bit of a buffer, you know? Here's a weird analogy, but Robert, do you have, and this is a long shot, do you have a pull-up bar, a doorway pull-up bar, Robert?
Yeah, I do.
I feel like, yeah, everybody's got to have one, right? Did you wrap a towel around the ends of it so that it wouldn't damage your door?
No, it came with like some padding already to it.
Okay, so that padding, that like padding, that's kind of like what a meniscus is. It's really there just to kind of take some of the impact. I don't know if that analogy works, but that's kind of a difference between the two. Oh, look at that. That's kind of cool. I'm sure that's not actually a zoomed in picture of fascia. I'm sure that's totally its own thing, but that's what you kind of probably looks like. So then we have our actual ligaments, right? So a ligament's job is to, and that's actually another distinction here. That's why like it's not even necessarily a ligament, but it is kind of made of a similar material. Ligaments' jobs are to attach bones to other bones, right? Your meniscus doesn't actually attach anything to anything else. It is attached to your tibia, but it just sits there passively. It's not attaching your femur in any way. It's just creating a little bit of like a concave shape. You've also got special materials throughout your body called labrums. So what a labrum is actually this little sort of flap that you'll see in here, right? That is there to like create a little more concavity. It's almost like the meniscus of your ball and socket joints. But that's what a labrum is. And so sometimes you'll see like labrum tears in either the shoulder or much more painfully in the hips. But that's like a labrum is just there to kind of act as a bit of cartilage and deeper, make the concave shape of that joint even a little bit deeper. Same thing is true for your menisci, your meniscus left and your medial and your lateral meniscus. Menisci just sounds, I've been using that word for years and I still don't believe that that's the plural. My brain is just like, it sounds so natural. I've never gotten over it. All right. So let's look at the ACL, right? The ACL, anterior cruciate ligament. This is a common tear that happens for overstretching that anterior cruciate ligament. And so very, very common, often involves non-contact, usually during planing and cutting motions, like I said. And you can see it's this ligament right here. So you can see it's the one that's in the front, that's your anterior, and it's a cruciate ligament. Cruciate actually is referring to like crucifixion in this point. That's actually why they named it. So you think of like the cross, right? It is crossing just like your posterior cruciate ligament is. And so you have sort of a crossing motion between there. So the one in the front's the anterior one, the one in the back is the posterior one. So that's your ACL versus your PCL. And I don't even think we mentioned PCL tears here. Yeah, we don't even bring it up. PCL tears can happen. They're just super rare because a lot of times in order to like tear that ligament, you got to be twisting in the other direction, but there's plenty of room to move in that direction. And you kind of need to have like your leg fully straight. It's just like a motion that humans don't make that often. It's not that you can't tear it, it's just really uncommon. And so there's your cruciate ligaments, your ACL that's in the front, your PCL is in the back. And then you've also got your MCL ligament and your LCL ligament. And so the MCL ligament is this one right here. That's your medial collateral ligament, which we're seeing here. And you've got your LCL, which is your lateral collateral ligament. So they all have like the same like C letter in the middle, but they mean different things for half the list. So tibial or medial collateral ligament, right? That's this one right here. This is very commonly injured during like collisions. So this often happens. A lot of times you're going to see tears in this ligament if you get somebody who does like a low tackle. Like this is where if you guys are NFL fans, you might remember, you know, the NFL has been trying harder and harder to reduce the amount of like head trauma associated with like playing professional football. And so like they've been encouraging players, you know, to tackle lower and lower and lower. But there was like a point in time where like a lot of the players kind of pushed back on it. And they were like, no, we don't want to deal with these like super low tackles because that takes out our knees, right? Like that often, you know, and that'll end our career. And the NFL was like, yeah, well, you know, your knee getting hurt is not as bad as traumatic head trauma. So the NFL kind of didn't listen, but which sounds like the NFL. But what they were often talking about is they were citing a lot of like MCL ligament tears. And so it's the medial side, right, which means it's closer to the midline. So your MCL ligaments are the ones on the inside of your knees, right, versus your lateral collateral ligaments, which are the ones on the outside of your knees. And often what happens here is you'll have somebody get tackled from the side, right, like this, right? So what'll happen is if somebody were to hit me from the side, right, both of my knees would, you know, they would both move, okay, not far enough. They would both go like this, right? So here's the thing, this one, I'm stretching that lateral side, but I'm used to stretching that lateral side, right? Like I squat and I push my knees out, right? But if I go like this, right, I'm overstretching, and I am like crazy putting like too much stress on that medial side, right? Because now I'm getting tackled here, and now this ligament on the inside is being stretched. It's very similar to, go to the other side of the body, that lateral ankle sprain we talked about yesterday, right? When somebody rolls their ankle like this, they're overstretching the outside. Well, if you cave my knee in like this, I'm overstretching my inside. And so that's what often happens in MCL tears. Fairly common there, but usually commonly associated with like contact injuries. You're not going to see too many people like doing this kind of motion without getting hit. So those are the most common. Again, like I said, you do also have lateral collateral tears. They're just not quite as common. That would be, you know, you'd have to kind of have like your front leg, you'd have to have like one leg forward and then get tackled from the side like that. And it's just not, you know, usually you'll be hit from the other side first. Oh, we did have PCL tears in here. I just didn't put it in the, I just didn't put it in the notes because it's so uncommon. All right, pass Brad, I see you. All right, so PCL tears, pretty uncommon. It's also a thicker ligament, so it doesn't, you know, it's a little beefier. But usually it's in direct contact with like some type of opponent or some type of like playing surface. Usually somebody has to like kind of get hit here. And then lateral collateral tears, really infrequently injured because again, you kind of got to get hit and then move the leg out rapidly this way, which we just don't have much room for adduction. You know, if you get hit from the side, you know, what's going to end up happening is one leg's going to hit the other one. It's not going to keep traveling in most cases. So those are sort of what we see in the most common like ligament tears. It's going to often be your ACL or your MCL or your meniscus. Now, other types of injuries that we tend to see, and these are more like overuse injuries than they are contact injuries. We have things called like patellar tendinopathy, right? Remember yesterday I talked about like Achilles tendinopathy, and that's where that Achilles tendon rubs on the bone. Well, patellar tendinopathy is more commonly referred to as jumper's knee. And I'd be willing to bet that somebody in this call has probably experienced this for a little bit. Nicholas, I know you do like a lot of like dance and stuff with like a lot of jumping. If you've ever gotten like achy and like an achy pain sensation below your kneecap, like right in here, that's often what we refer to as patellar tendinopathy. They call it jumper's knee. It's really common in like basketball players. And it sometimes happens, it's as simple as just losing flexibility in your quadriceps. And so I honestly am not a huge fan of this stretch. I know this is like the classic stretch that like you think of when you think of athletes, right? They're doing that like, foot up stretch. I'm honestly not a huge fan because like most of the time people have like the number one common thing we see is like tight hamstrings. And so all you're doing right there is like tightening your hamstring and you're loosening your quad, which further tightens your hamstring. So I'm not a real big fan of that stretch. But if I do have a client who has like an experience in like jumper's knee and patellar tendinopathy, I'm going to do everything I can to like loosen up the front of their thigh, because what's happening is it's tightened up and now it's rubbing on the bottom of the kneecap, the bottom of the patella, and it's rubbing on the shin bone itself. And so they'll get inflammation there. And it can be, painful. And shocker of the year, it's very common in athletes who do a lot of jumping. And then here's the one. As a runner, I've been very fortunate. I haven't had too much of this myself, but it is a plague in the running community. Iliotibial band syndrome, or IT band syndrome. And basically, this is where this overactive muscle here, this classically overactive muscle, the TFL, that tensor fascia latae, that jerk of a muscle that loves to get overactive on so many people, it gets tight. And then you got to remember that your TFL actually becomes your IT band. And your IT band is this group of fascia actually that runs down. I mean, there's a little bit of debate here. It's like, is your IT band a muscle? Is it fascia? Like, what is it, And so if you look at it, if you look at the IT band, see if I can find a kind of a different picture here. I want to get another one of those really cool pictures like we saw a little bit ago. Yeah, we're just not gonna get one. That's kind of cool, right? Yeah. Okay, see, it's very white. It's very fascial. It's just not much of, it's just not much of a muscle in the sense of like it's normal. It has contractile proteins. It totally does. It just tends to mostly be fascia there, and it's there to create some stability all the way down. So we like having an IT band. It's just the freaking thing gets overactive all the time. And so like, that's part of your TFL and your IT band. There was a great picture I just saw a second ago. That like kind of showed it really well. Yeah, I love this one. Look at this. You can see here's the TFL fibers and there's the IT band fibers. And you can't really see it here, but like also your gluteus minimus fibers actually are going to run down back there as well. So IT band syndrome, very, 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 very common because this fascia will get really tight, and you're going to either get runner's knee or runner's hip. Both of them are really common. Runner's knee is where you'll actually start feeling it on that little knob on the outside of your knee laterally. You'll start feeling like a rubbing sensation there. Gets very, very painful. Usually people will describe the pain as being worse when they are walking downhill or going down some stairs, because it's like the letting off motion is usually where that fascia will kind of rub for a second. Or they'll get runner's hip, where it will rub on the outside of that greater trochanter of the femur up here. So we'll see that happen. And so that's very, very common, especially when we see excessive knee valgus. When we see those knees cave in, you're asking for IT band syndrome. So very, very, very common there. And here's a fun little fact. You'll notice we spend a lot of time, like you'll hear me say like you should foam roll your TFL, but you don't really ever hear me say like foam roll the IT band. When I was in school, we were totally told like foam roll the IT band all the time. That thing's tight, you got to loosen it up. And now we're finding like more and more and more that by rolling your IT band, you kind of, it's so fascial and so not like a traditional muscle that we find that like when you loosen it up like that, it ends up it being so painful that people are like, ah. and it actually creates more tension in the end, and kind of makes the situation worse. So in the last few years, we've seen less and, we've seen more and more people being like, you know what, don't roll the IT band, just roll the TFL. You can loosen this up, but leave this alone. And by the way, like I think that there's still room, maybe this is just me being stubborn, or me being, maybe I'm like the boomer of kinesiologists. So you guys can okay boomer me. But like, I was taught that it was okay. I've had some success rolling my IT band, but I do think that it takes like a little bit of mental awareness to be like, I am not going to whine or contract this muscle. I'm not going to scream. I'm just going to roll it and be calm and zen and let it relax. I think if you take that approach, I think you can have some success rolling it. But generally what people are doing when they roll their IT band, they're like, ah, and it ends up kind of tightening the whole thing up worse. So that's IT band syndrome. ITB syndrome, you'll sometimes hear people call it. And then you've got patellofemoral pain. And this one is sort of just general aches and pains. So this is knee pain, right? Pain in the front of the knee. It's a pain in the knee. I'm a real boomer. So you can see this is often you can see these little arrows here. The reason we're drawing these arrows is because a lot of times, and the reason it's called patellofemoral, right? This is your patella. This is your femur. And so you'll get pain where these two bones are kind of rubbing on each other. And so these arrows are here to represent poor patellar tracking. So your patella actually moves up your femur when you go into like a knee extended position, and it drops down during other motions, right? So when you're moving your knee around, your patella is actually designed to move. And if it doesn't move properly and it tracks in the wrong direction, because maybe you have a muscle that's pulling it this way or that way, it's going to grind because it's moving in this little groove, right? Like picture something like kind of shaped concave, kind of like that, right? So it's designed to like move in that groove, but if it like ridges up over here, ridges up over there, right? That's going to create a little bit of that like rubbing sensation. So that's where we get patellofemoral pain, and you'll have clients who have poor patellar tracking. Usually when they are squatting or going up and down stairs, both of those are really painful because they're performing knee extension and knee flexion over and over and over again. So their knee's not moving the way it's supposed to. It's grinding, and they can kind of feel that pain. So this often you got to figure out like what direction it's being pulled in, if it's being pulled medially, or if it's pulled laterally, or if it's being pulled, if it's not moving in these directions the way it's supposed to, because like it can't. Whatever's causing that tracking, it could be an adductor problem if it's on the inside. It could be a TFL IT band problem if it's on the outside. An adductor problem if it's on the inside. It could be a really tight rectus femoris, or vastus lateralis, or vastus medialis, right? So you kind of got to look at that and be like, what angle is the kneecap pulling in, and what muscles do I need to loosen up? Like, do I stretch this quad muscle or that quad muscle, or the adductors, the IT band are the most common ones. Any questions about any of those? I almost said diseases. Conditions? Symptoms? Feeling good, guys? Cool. All right. Let us look at the anatomy. Let's look at the bones here. So bones are actually pretty simple. You get your femur. All right. It's the big bone. That's the femur is like that's the caveman bone. Whenever you see like a caveman with like a bone for a weapon, it's probably a femur. Largest bone in your body. Then you get your tibia, which is also a really long bone, depending on who you are. And that makes up your actual shin bone. And then your fibula, which is on the outside. So there's that one bone, two bone structure that we talked about a little bit about yesterday, right? And so you can see the femur here sits on top of the tibia, and then the fibula is there to allow for rotational movement. So just really quickly, I do want to kind of show you the connection between your fibula. You'll notice it's got two joints for these bones, right? You got the fibula head right up here that sits underneath your tibia, right? So there's your tibia, and then your femur would sit like this. But then down here, it actually is cut off by my frickin' computer. Oh my God, come on. I get so mad. All right, so there's your fibula. It runs down and actually goes down further. And that's that knob on the outside of your ankle, right? That's that little knob that you can see down there. That's your, what's called your lateral malleolus. And so your fibula has a connection here and a connection down here. So these two bones come together and form two joints on each other. And so this is what that, by having that second bone structure, by the way, that's what gives you rotary movement. Just like in your forearm, you're able to do like pronation and supination, you're able to pronate and supinate your ankle. So as we are looking at it, right, that's the femur, that's the fibula, that's the tibia. And then you got the little floater bone here, your sesamoid bone, that is your patella. That's the knee cap, right? And that, like I said, is a little floater bone that is designed to kind of move up whenever you are moving your knee around. So actually, I want to show you really quick a little bit of like motion of the knee. So knee joint patella movement. Is it the one I want? Yeah, I think so. Or is it this one? It's this one. All right, so take a look.
So let's look at some movement.
Oh boy, yeah, I remember this video. This video is great. So here's your patella, right? You know what? I'll let this guy talk, actually.
So let's look at some movement of the knee. Here's the medial collateral ligament. Watch the movement and flexion extension of the medial collateral ligament.
Look at the inside of the knee.
Here's the lateral collateral ligament.
Outside of the knee. Attached to that fibula.
And you can see that the movement of the femur on the tibia, and also look at the ligament moving forward and back, and look at the whole movement of the whole joint here. You can also watch the patella and the patellar tendon. We'll just do that one again. Maybe watching the patella and the patellar tendon sliding in that fashion. See how the patella slides in the groove there, intercondylar space, intercondylar groove. Here we have patellar motion from above.
I love this. You can kind of see
flexion, extension.
The ridge, right?
And you can see it slides in and out of that groove. Normally, it should stay right in its intercondylar space. These are the primal pictures slides.
By the way, he's calling that little space there, he's calling that the intercondylar groove. Remember when we talked about like bony landmarks and you've got condyles? Condyles are an example of a projection, right? So like you've got depressions, right? And you've got projections on your bones. Condyles are an example of a projection. So like this is a condyle here and this is a condyle here, even that's a condyle, right?
These are the primal pictures slides. Here we have what's called patellofemoral tracking. This is the tracking that should take place where that patella stays right in that groove in the intercondylar space. Here we see again patellar ligament, and we see the course of it tracking. Let's do it again. And it should slide evenly and smoothly through that groove. And when sometimes there's an imbalance in the muscles, particularly the quadriceps vastus muscles, for the most part, it could be other muscles, but the vastus muscles, it will not slide in that groove and it'll create a lot of pain as the patient flexes and extends their knee. Here's more tibial femoral motion. And you see the posterior collateral ligament and the anterior collateral ligament, posterior collateral ligament, anterior collateral ligament. I'm sorry, posterior anterior collateral ligaments. And here we see another one. These are so cool, I just thought I'd put them all in. You can see the collateral ligaments. And here's the lateral collateral ligament and the cruciate ligaments. I mean, I said collateral, I meant cruciate ligaments. All right, let me look at this one again. So the cruciate ligaments, anterior and posterior cruciate ligaments. The medial collateral ligament, the lateral collateral ligament, the anterior and posterior cruciate ligaments firing. Okay, so with those in mind.
All right, so So that's kind of the motion that our knees are supposed to make, right? Like that's, you know, the patella is meant to move in that groove, and it's performing flexion, extension, all of it. So it's got a little bit of a rolling action, right? And it's got a little bit of a sliding action, a little bit of a rolling action. So this is where we talk about like the difference between like your knee joint proper versus like your patellofemoral joint. So there's actually 3 joints here that we are going to be talking about today, right? You have got your proper knee joint, right? That's your tibia and femur, right? That's your tibiofemoral joint. So where your femur sits on top of your tibia, the place where those 2 bones come together, that's your knee joint, right? But then you also have your patellofemoral joint, where your patella bone is sitting on top of your femur, right? So that's the patellofemoral joint. Then we also have the superior tibiofibular joint. And the reason it's called superior is because it's the one, you know, there are 2 tibiofibular joints, right? Your tibia and fibula touch each other up top, and they touch each other down below. So the superior one is the one that's above, right? Like I said, a lot of terms. This is why we kind of went over all that terminology for like 6 straight days before we even got into actually looking at all of this. You know, and you guys are getting a 12-day kinesiology class. Traditional kinesiology, you get a semester of that guy talking, you know, for 2-3 hours at a time. And I'm sure it's, you know, great because that guy's smart. But that's kind of what we're talking about in these different joints, right? And this is a fun one. I love that they got this little one here. Your superior tibiofibular joint, okay? That's this area right here where the fibula is intersecting with the tibia, acts as an attachment site for the biceps femoris, which is a hamstring muscle. And you'll notice I'm glaring because this muscle is evil. It's really important. I say it's evil because it's just really tight on me and it makes me cry. But like this biceps femoris muscle is a muscle we're gonna spend some time talking about today. When you have a knees cave in client, it is often because of this biceps femoris muscle. This little short hamstring muscle that runs from about here and inserts right here. And it's a freaking jerk. So we're going to spend a lot of time talking about that muscle today. All right, so that's sort of what we're seeing in terms of those bones, right? And in terms of those joints. Now, some other special structures, like I said, your knee is very special. It's got a lot of special structures in it. It is a synovial joint, right? Like most of the joints in your body, it is a synovial joint. So it's got a little cavity, and then it's filled with synovial fluid. Which is that kind of egg white material that acts as like grease within our muscles, right? That's sometimes people refer to it as the capsule of the knee. And if you ever burst that capsule and your body goes, oh no, we need more fluid, it'll flood it. And then sometimes you'll see it leak around, and you'll get people who get like water on the knee is what people will call it. Is a little disturbing looking, but you'll see like where their knee will basically inflate like crazy. And that's just basically their body being like, we don't have enough synovial fluid, fill it up, you know, and then it's leaking and stuff. This is very common in people who have worn down the cartilage in their meniscus, right? So if they've worn down the cartilage surrounding the outside of their bones, or they've worn down their menisci, what'll often happen is they'll start getting bone on bone action, and that tends to be very painful. And then the body freaks out, and your immune system goes, more fluid, you know, trying to kind of grease the area, but it doesn't really work. It ends up being more painful. We love our bodies, but sometimes our immune system sort of, you know, screws up a lot of times. Mosquito bites are a good example. So your meniscus, right? Those special little structures in here, they're there to be like cushions between your bones. They enhance your stability. You're also going to see fat pads in here. So you do have some fat pads that are in this joint as well. You can see one back here and one up here. And your fat pads are actually there to provide a little bit more stability. Again, this is why you've heard me say this joke before, but like when we talk about somebody's body fat percentage, it's like you got 16% body fat, which means you have 16 pounds of body fat on your body. And then your client goes, okay, so I need to lose 16 pounds. And you're like, no, you have a lot of essential fat that you need inside of your body. This is part of that essential fat, actually, these little fat pads here. You're going to find these, especially here in the knee. And then you're going to see bursa. And your bursa, or bursae, which is the plural version of a bursa, is basically these little fluid-filled sacs. And so these little fluid-filled sacs sit inside there. They're also there to absorb like shock and friction. And you can burst your bursa, and that can sometimes lead to fluid in the knee as well. Basically, you can think of, and this is the weirdest analogy, but I had a student say this a long time ago, and I was like, I'm gonna remember that because it actually is kind of a good analogy. But if anybody has ever seen, this is gonna get weird, it's gonna get inappropriate. If anybody has ever seen like an old school breast implant, it's like a little fluid-filled sac. That is exactly what your bursa look like. They sit in our joints. There's the shoulder bursa. There's a bursa right on the outside of your hip here, and they're just there to reduce friction. You know, they're like packing. They're like those little when you get an Amazon package and they filled it with those little like air sacs, right? Imagine that, but instead of filled with air, it's filled with fluid, and that's what your bursa are. So they're there to kind of reduce all that friction. All right, that is all the special stuff. We've done the bones, we've done the injuries, we've done the bones, we have done the joints, and we've done all the weird special connective tissue. Do you guys have any questions on that stuff before we move into one more concept before getting to the muscles? Any questions there? Okay, all right. So let's go ahead and take a look at what causes some of those injuries we talked about, right? Remember, like, injuries don't have to be caused by contact, right? They can be caused by you sitting in the inappropriate posture. So when we say someone's knees are caving in, what we're describing is a term known as knee valgus. So this is a term that you're going to hear. When I say knee valgus, I want you to picture knees caving in, okay? And what does that mean? It's like, well, what if that's just how our knee sits? It just doesn't. I know, and we know that it doesn't, right? Like your femur's not supposed to sit that way. It's not structurally designed, unless you're incredibly unique, like unless your bones formed in a way that they're not designed for like a typical human, right? And so how do we, like, when I say that, it's like we have a measurable angle that we see as the normal angle. And it is different between men and women. But that angle is called your Q angle. And this is a term that you do kind of want to know. And it's also something you want to sort of train your eye to spot. You want to be able to look at someone's hip and look at their knee and sort of like estimate their Q angle. What a Q angle is, it is a central line of pull, so you're going to draw a line, from for the quadriceps that runs from the ASIS to the center of the patella. So I apologize, we haven't really done a lot of hip anatomy yet, but your ASIS is this little notch on the front of your hips, right? If you knock on your hips and you feel like where that bone's really exposed, there's really not like a lot of tissue between like the skin here and like the bone itself. That's your ASIS, that's the front of your hips, right? And what that stands for is that is the anterior, because it's on the front, superior, because it's one of the highest points of your pelvis, iliac, because this ridge right here is known as your ilium, and it's called spine because it's also the ridge. It's like almost like the spine of your pelvis. And so that's your anterior, superior, iliac, spine. You got a notch back here in the back, which is your posterior superior iliac spine, your PSIS. And so, I'm not going to spend too much time on this right now, but when we talk about an anterior pelvic tilt, one of the ways we look for that is we draw a line from the PSIS to the ASIS, and if that angle is downwards, that's an anterior tilt, versus if that angle is upwards, right, that's a posterior pelvic tilt, or flat spine, which you see in Ray. So that's how we look at that tilt. But the ASIS, right, if you were to draw a line from your ASIS to the center of your patella, the dead center of your knee. So I'm standing like this, draw a line from here down to the center of my kneecap. ideally, if you were to take a protractor and measure that angle should be about 15 degrees in me. If I were female, that angle should be about 20 degrees. So you'll see women have a wider pelvis, and so their ASIS is further, lateral. And so the angle is going to be a little more intense versus guys who tend to have a little bit more narrow hips. So we're going to see slightly different. So women will have a higher Q angle due to having a wider pelvis. So here's what we're looking at in a generally like altered Q angle, right? So if we draw a line here, and you notice like this person's knees are caving in, right? They're going to have an excessive Q angle, right? They're going to have a deeper, wider Q angle. And the problem with that wider Q angle, take a look. Do you see right here? Let's look at this original knee, right? See how the space between the knee, the tibia and the space between the femur, that's evenly distributed throughout the entire kneecap. It's an even amount of space. Versus here, you can see there's very limited space over here, and there's too much space over here, right? So now what's happening is the ligaments, that LCL ligament, that lateral collateral ligament, is getting used to being in this shortened position, similar to how in our ankle, lateral side gets used to being in that position. And then, if somebody gets like, tackled from the side there, maybe that'll overstretch that can cause that injury. Again, it's pretty rare because a lot of times you're not going to get hit coming this way. But you can see you're overstretching this ligament here, right? So then if you get hit further from the side, guess what? You overstretch this ligament even further. That's how we end up with an MCL tear. But then we also see that ACL ligament, right, which is running from here to here, is also in a stretched position. So now if somebody tried to plant and cut, they've already stretched out, and now it can't further stretch, and it's going to break, right? So we will see hip pain, we'll see knee pain, and you'll notice this is causing rotary movement in the ankle. Guess what? They're probably also going to have knee pain or ankle pain. So this is why it is so common to see feet turn out simultaneously with knees cave in. Remember I mentioned those two are often linked together in terms of our movement compensations. And then that's causing pain in the lower back as well. So you can see low back pain, hip pain, knee pain, and foot pain, all from having an excessive Q angle. And that's what we're looking at. That's why we call it knees cave in. Let's take a look at some more pictures here. So excessive Q angle, or knee valgus, right? So again, yeah, question.
Hey, Brad.
Yeah, what's up?
Don't we call that knock knee?
Yeah. If we look up like knock kneed, I looked up like it was like knock jokes. Yeah, knock kneed is going to be sort of a cave in motion. Now okay. This is a little bit different. You can see like this is an extremely excessive version, but you can also see there's some asymmetry here. This is sometimes when you see like knock kneed, it can be something. I would assume this person had rickets when they were a kid. So they didn't get enough calcium or vitamin D in their diet. And so that caused like a bone formation. Rickets is basically a disease where your bones are actually like curved because your bones weren't able to grow the way they're supposed to. So yeah, sometimes you're gonna see that. But in this version, we are more looking at it from like, they've got a standard structural skeletal system, but through bad habits, they have sort of given themselves knock-kneed, they've given themselves that knee cave-in posture. So here's what it's supposed to look like, right? Here's the wider, here's men versus women. You can see like this is wider, but it's still within normal ranges, right? Versus like an excessive Q angle, where we see that sort of knee cave-in situation. Yeah, hold on. Knee valgus, right? So knee valgus, yeah, this is great. So you can kind of see it here, right? It's really slight, right? Like this looks like just like your normal, but notice how the foot is slightly turned out, right? The foot is ever so slightly turned out. And then if you draw a line from the patella, it's not, I'm trying to go perfectly straight here, but they're lining from their patella. It's lining up with their big toe. It should be lining up with their second and third toe. And then in this picture, I wish it went up higher, but if you were to go all the way up to their patella, you'd see a much wider angle here. So they are internally rotating, they are adducting, and they are externally rotating here, and they're externally rotating here. So that's what we're seeing versus this version, which you'll notice is lining up with the second and third toe, and then that angle is not quite so deep. So that's knee valgus, right? Again, it's going to look something kind of like this. So that's an excessive Q angle, now more commonly referred to as knees cave in. Now, there is also going too far in the other direction. We're also, I didn't even sign the PowerPoint. You're also sometimes going to see excessive knee varus, and that's a lack of Q angle. So knee varus is going to look like this. And that's where you'll see like a lack of Q angle, where you'll have like a bow-legged posture, you know? Zooming in. So there's varus, right? Where basically the bones are just like whoop, 90 degrees on each other. There's no Q angle. The angle is flat, you know? And that's where there's going to be too much space on the outside, not enough space on the inside, versus that knees caving in posture here. Versus like normal posture, right? Which we want to see like some angle, but not too much. Does that make sense to everybody? Knee valgus, by the way, commonly associated with flat feet. Knee varus, commonly associated with like high arches. And that's kind of what you're going to see. So both of those are bad. That's not what we are looking for. So we got to look at what muscles are causing those angular changes. Because remember, when we look at knee valgus, I got one more picture I want to find, and I know it's up here. So knee valgus. Oh, you know what? Actually, what I want to look up is pronation distortion. That's where it is. Come on. There's this one picture with a bunch of arrows that I just love so much. There we go. Oh, this will work. This is real. Oh, there it is. Okay, so here's what we're seeing in pronation distortion. When we are seeing knee valgus, right? Simultaneously with foot pronation from yesterday, we are seeing internal rotation of the femur, which is causing internal rotation of the tibia, which compared to your femur is now externally, you know, like we see a deep angle there. And then we're seeing pronation of the foot, right? And that's causing hip pain. And then maybe that's going to cause like, you know, facet pain up here as well. So that's what we're going to see there. And then the one other one we are also seeing is adduction of the thigh as well. So adduction and internal rotation of the knee. All right, let's go ahead and dive into the muscles that are causing all this. So the first one, we're starting off with the devil. To be fair, we're starting off with like the half devil first, and then we're going to do a real devil after that. So the first one we're looking at is the biceps femoris long head. So this is an example of where, you know, how many muscles do you have in your hamstring complex? You've got the biceps femoris here, the long head, the biceps femoris short head, your semimembranosus, and your semitendinosus. So there are 4 muscles to look at. However, and I think this is a test question, so don't fall for this, there are 3 muscles in your hamstring. 3. I know that there's the biceps femoris long head and short head, but technically they are 1 muscle. They just have 2 different sets of fibers. So this is 1 muscle, this is a muscle, and this is a muscle. Okay, so the biceps femoris long head is going to run from all the way up here on your pelvis, and it's going to run down and insert right here onto that fibula. So that's important to remember. That's your fibula right there, not your tibia, okay? And that's why this is associated with rotary movements. So it concentrically accelerates knee flexion, hip extension, and tibial external rotation. So this muscle's got 3 jobs, right? And again, anytime we see a muscle with multiple jobs, it often is overactive. So this is the lateral aspect of your hamstrings, is the outside part of your hamstrings. And its job is to shorten during knee flexion. So it is in charge of this. It assists in hip extension, right? So we're seeing knee flexion, hip extension, and it does tibial external rotation. Okay, so it does this. And this is what's kind of fun. I want to show you guys one cool thing about your knee. Your knee actually unlocks at one point. Right now, stand up and stand on one leg and try to, from the knee down, externally rotate your foot. So stand on, hold on. Stand on one leg and try to rotate your foot away from you with a straight leg. You will notice that it cannot be done. You cannot rotate. You can rotate from your hip up here, right? But you cannot rotate from the knee down. But if you bend your knee, then you can rotate without rotating your hip just on the outside there. You can rotate from here. So that happens after your knee gets bent to about 30 or more degrees. So after about 30 degrees, your knee unlocks, and then you can cause tibial, that's the shin bone, external rotation, and then you can rotate it back to internal. So what muscle causes that tibial external rotation? The biceps femoris. This is the example of the long head, and then here's the true devil. This is the true devil's muscle right here, and that's the biceps femoris short head. This is commonly overactive on everybody, just about everybody. So this doesn't run all the way up here. This originates actually about halfway down the femur, so it actually starts in the middle of the bone. You can see there's its tendon right there, and it runs and inserts onto the same place. So it almost does the exact same thing, except that it cannot assist, this can assist in hip flexion because it's attached to the hip. This can't assist. This can only do knee flexion and tibial external rotation. So that's the only thing that your biceps femoris short head, that's the only thing that it can do. So here's how you stretch this muscle because it is so commonly overactive in everybody. So take an elevated surface. So we know that our hamstring muscles perform knee flexion. So if we want to stretch them, we need to go into knee extension, right? But we also know that they assist in hip extension. So if we want to stretch them, we need to go into hip flexion, right? So I'm going to go right here into a hip flexed position. I'm in hip flexion, and I've already got my leg straight, so that's also knee extension. So I'm in knee extension, I'm in hip flexion. But remember, it does tibial and external rotation, right? So if I go like this and turn my foot away, that'll actually take the stretch off of this muscle here because now the muscle is contracting to externally rotate. So what I need to do is I need to internally rotate, but I don't really want to be in this big super internal rotation movement. So what I'm going to do instead is I'm going to move my hips to cause that internal rotation. So bring your hands together, right? And just line them up with the dead center of your pelvis, right? Line them up with your belly button. So I'm going to go here, and then to get the outside part of my hamstring, what I'm going to do is I'm just going to rotate. I'm going to keep my foot flexed back towards me because that's also going to stretch out my calf, which is going to further pull down my hamstrings. Keep my leg nice and straight, and I'm going to rotate across my midline. And as soon as I'm facing away here, now basically what I've done is I've pulled my leg across my body, right? And when I go like that, you're going to feel a big, crazy deep stretch right behind the back of the knee on that fibula. So everybody try that. It is the world's worst stretch because it is the devil's muscle. I just hate this muscle so much. It's so tight. I've been working on it for years and it's just like, nope, never gonna loosen up. So that is your biceps femoris, long head and short head. Particularly, that rotary movement is very much the short head. So when you're trying to foam roll your hamstrings, honestly, your biceps femoris short head is also sort of located underneath your long head. So it's a somewhat deep muscle. It really is kind of difficult to put enough pressure on your hamstring. So one of the things that I find works really well, I will put a lacrosse ball right here and do what's called a pin and stretch. And I actually don't have a lacrosse ball on me, but I do have a plastic cup. Like that. All right, so a pin and stretch is actually where you can take a lacrosse ball and put it underneath your thigh like this. And then what you're going to do is you're going to stretch that muscle out. You'll feel it, roll along the muscle there. And that's a really great way to kind of loosen up that biceps femoris and give yourself a little massage back there. That is one of my all-time favorite stretches, actually.
That one looks like it hurts.
It is not great, but it feels really good afterwards. It's a good hurt, if that makes sense. You can also, if you can manage to find a good massage therapist, I will say they can get into this joint pretty well, and they can kind of loosen that up for you. But it tends to be pretty tough to get in there by yourself with like a lacrosse ball. But if you go get a massage and you tell your masseuse or your masseur, you're just like, hey, do me a favor, can you work on that biceps femoris insertion? If it's tight, they can get in there with their thumbs and kind of dig it out. And it does not feel great. But it feels great afterwards. So that's your biceps femoris. Do you guys have any questions on that one? That's sort of a technical stretch. Any questions on how to perform that motion? Everybody feeling good? Okay. Really quickly, going back to our notes really fast. So the biceps femoris, that lateral hamstring muscle, its isolated function, its action is to concentrically accelerate knee flexion, hip extension, and tibial external rotation. It rotates your tibia this way, which when you look at that in, when you look at a knees cave-in situation, right? If I'm squatting like this, right? This is now, my tibia is external, right? It's out here. And that's why when we see knees cave in, that's why we know, or if somebody's feet are flattening, that's why the hamstring muscle is the tight muscle on this list. Seems kind of weird, right? You're like, why would my hamstrings affect my ankle? Well, this is why, because one joint affects another. So that's your biceps femoris long head, biceps femoris short head, the lateral and posterior portion of the hamstring muscle. This is going to concentrically accelerate knee flexion just like the other one did, but it can't do hip extension because it's not tied to the hip. And it also does tibial external rotation. And then obviously it eccentrically does the opposites, right? Our integrated function is the opposite of those two things. So then we have like the meaty part of your hamstrings, right? This is the medial hamstring. This is like the sort of big meaty part. When you see somebody who just has like huge hamstrings, like again, I'm gonna go back to Arnold. Arnold Schwarzenegger, like we just look at the man's hamstrings, they were ridiculous. You can kind of see the separation there, right? So like this inner portion here, look how freaking huge that is. That's the medial hamstring, right? So the inside part of the thigh. Good Lord. For the right, he was crazy too. Arnold used to say, if he didn't throw up on leg day, he didn't work hard enough. That's a crazy person. So this is your medial hamstring, these two sections here. This is what is known as your semimembranosus, which is this sort of longer, thinner one, and your big, fatter one. And then you've got your semitendinosus, which is the longer, thinner one. Again, they both insert onto the same spot. Notice how their insertions here are the same for both, right? But their origins are just slightly different, although they're not doing a great job showing it here. Semi-tendinosis. Their origins and are just slightly different, but their insertions are pretty similar. So you can see here, right? One's a little bit lower, one's a little bit higher, and they both run down and what am I doing? They both run down and they insert right over here. That's your semimembranosus, that's your semitendinosus. Again, their job is to concentrically accelerate knee flexion, so nothing surprising there. Hip extension, and then this does tibial internal rotation. So when you have a client, you'll notice if we go to NASM's overhead solutions table, if we look at that and you see the knees caving in situation, always pick the wrong one. There we go. Knees cave in, you're gonna see probable overactive muscles. What's pulling during the caving in? The biceps femoris, primarily the short head. And then underactive muscles, you'll see the medial hamstring. So, you know, we got to strengthen the inner portion of the hamstring and stretch out the outer portion of the hamstring. So how do you strengthen the inner portion of the hamstring? Well, you're going to do hamstring curls, you know, or you're going to do a bridge position and you'll do it with just, you know, neutral feet. Don't let those feet turn out. Strengthen those hamstrings. Don't let your clients turn their feet out. You'll see so many times. Let me see here. Hamstring curl machine. Let's take a look. This is, you know, this is a, whoops, this is, you know, these are meant to be like demos. These are pictures put up on the internet by trainers. And there we go, instantly. This is clearly a person who is a model and not an actual trainer. Do you see how her feet are turning? She's on this curl machine and she's got this weird angle with both of her feet. Not what we are looking for. We want to make sure that we get it into a neutral position with those toes. And so you wouldn't think that the angle of your feet is super important. There we go again, right? External rotation. See how both those toes are pointing away? That is working on the external part of the hamstring, which is commonly overactive. That's bad form. It's slight. It doesn't look like much, but that is not what we want to look like. Yeah, those are your hamstring muscles. Any questions on the hamstrings before we go to the quads? We're going to the quad. Okay, your quadriceps are 4 muscles. That's why they're called the quadriceps, right? So we're going to see 4 separate muscles here. You are going to see you're going to have 3 vasti muscles, and you're going to have 1 extra muscle, which is your rectus femoris. That's sort of the king of quads. So your vastus lateralis is the lateral quadricep. You've got your vastus medialis, which is the medial quadricep. And then you've got your vastus intermedius, which is into the middle of the 2 of them. That is a dead center, right? So vastus lateralis pulling on, you can see it pulling on the patella laterally. And then you see the vastus medialis pulling on the patella medially. The vastus intermedius pulling kind of medially, but also like superiorly. So it's going to pull up. And then you've got the rectus femoris, which is actually going to run down, and it looks like it's inserting on the patella here, but it's actually running all the way down to the knee here as well. And so that is one that you'll notice attaches from the hip. All 3 of the other ones started on the femur, right? So femur, femur, femur. And that's why the 3 vasti muscles, your vastus muscles are in charge of just knee extension, but your rectus femoris does knee extension and hip flexion. So we're getting a little bit into hip stuff today as well. And this is where, you know, we really can't just do one joint by itself. Sometimes these muscles are going to show up on 2 lists. So you can see all 3 of them here, right? Medialis, lateralis, rectus femoris. I guess you can't really see intermedius because it's underneath the rectus femoris. Okay, so what does your vastus lateralis do? It concentrically, when it's shortening, it accelerates knee extension. So when you're on that knee extension machine, you're working the vastus lateralis. But guess what? The vastus medialis does knee extension as well. Oh, and actually really quick, I forgot to say something. Your vastus medialis is often, and they don't say it in your book, but it is often referred to as your VMO because its full name is vastus medialis oblique. And it's called oblique because oblique means off to the side. That's why your obliques are the side abs. So the vastus medialis, it's sometimes referred to as your VMO. So this muscle right in here. So that's your vastus medialis, and it concentrically accelerates knee extension. So that's, totally the same. Look, notice how, like, watch, I'm gonna flip between the slides really quickly. Notice how the picture's changing, the name is changing, but all the writing, totally the same, right? Nothing difference there. And then look at this, vastus intermedius. 1, 2, 3, they all do the same thing. So in terms of memorizing, you got a little vacation. That is going to be easy. So your middle quadricep muscle concentrically accelerates knee extension as well. So that's their job. They do this, right? They are going to do the knee extension. So when you're doing a snap kick, that is your quadriceps muscles, your 3 vasti muscles: vastus lateral, intermediate, and medial. I will say this. They are slightly different. The distinction's not drawn in your book, but remember earlier I was talking about poor patellar tracking, right? And we were talking about how, like, sometimes people's knee doesn't move the way it's supposed to because one of the quadricep muscles gets overactive. If it's pulling medial, your VMO is underactive. If it's pulling lateral, your lateralis is overactive. If it's pulling superiorly and doesn't relax down, it's your intermedius. And that's why during poor patellar tracking and during, like, jumpers knee motions, we got to do that stretch right there. We got to work on that knee, but we do not want to do our quadricep stretches like this, where my knee is pointing away from me. I want to point it down. I want to make sure my spine is nice and level, and I want to go backwards, not to the side. That's just causing more rotation movement, right? And how many people do you see do that? They'll do, they'll do this freaking thing, and it's like, no, right? So those are your quadriceps muscles. And then again, if we go back to our list here, if we see knees cave in, one thing that you're going to see probable overactive, and this is actually where they will change the list slightly when you go from normal NASM solutions table to corrective NASM solutions table. So let me find the shorter version here. These are all the corrective ones. There it is.
Hey, yo, Brad.
Yeah, what's up?
The best way to find a good balance and a good stance is without shoes, right?
Oh yeah, for sure. When you're doing your overhead squat, yeah, always do it shoeless because your shoes put you into plantar flexion a lot of times,
Yeah. And
Unless
then you get used to that.
Yeah, right. Yeah, you get used to that shortened position. That's not great. Unless you're wearing these weird ones called Newtons. You ever see those shoes? I'll pull up a picture in just a second. Let me just go to NASM's website. Oh, there we go, first link. All right, so notice, like, knees cave in. Look at your probable overactive muscles. Adductors, right, that makes sense with caving in. Biceps femoris, there's that hamstring muscle. TFL, which is that hip rotator. We'll get to that tomorrow. And then vastus lateralis is on this list. So that quadricep muscle on the outside is sort of working, if you notice, like, your biceps femoris is directly behind that muscle. So both of these do just a little bit of internal rotation, although it doesn't say that in your book. It is responsible for a little bit of that. So that's where a lot of times people will have, and this is why you'll feel it too, because look, this is right next to your IT band, right? Which is right next to your biceps femoris. It's all of the outside part of your thighs, right? So, if we look at it, right, It's like this part gets tight, but then the IT band gets tight and the biceps femoris gets, so all of this like fascial area tends to kind of tighten up. And again, that causes that internal rotation. So, when you are foam rolling and stuff, if you're going to do your quads, you want to stay on the lateral aspect of your quads. You want to stay on the outside. So actually a slight knee pointing or a toe pointing in situation is going to expose that outer part of your quadriceps. And that's usually the part that you kind of want to like roll. Again, fair warning, it's not going to feel great. And then here you see underactive muscles, your VMO, that vastus medialis oblique. So sometimes you'll see this internal rotator, which is working with the medial, directly on the opposite side of the joint of your medial hamstring, ends up becoming underactive. So again, this is kind of an example of NASM watering down kinesiology, where they're just like, yeah, it does knee extension. But then later they're like, here's the overactive muscle. They don't really explain why. And they're like, wait a minute, why would this quadricep be weak and this quadricep be tight when, according to the list in my book, they are literally identical? Well, they're not perfectly identical. I don't know, it's a little lazy. So when you're doing knee extensions and stuff, again, the way you make sure that you're strengthening your quadriceps properly, get your knees pointing forward. Don't let them cave out. Again, I'll go back to my fake workout bench here. You don't want somebody doing their quadricep, their knee extensions like this, where their toes are pointing away, right? You want to make sure that they're doing it, toes pointing straight forward, no funky angles, right? And you'll notice, did you guys notice, like, even with my good demo, I noticed my ankle tried to rotate a little bit, and it's because I have a tight biceps femoris, because the biceps femoris is the devil. All right, let's move a little bit into the hip stuff today, because your hip does affect your knee. So we've got to look at the first hip muscle, which is part of your quadriceps group here, that rectus femoris, right? Rectus femoris. It's going to run from just below your ASIS down and insert onto the kneecap there. So it is in charge of knee extension, like I said, but it also does hip flexion. And that's why, when we are foam rolling your hip flexors, a lot of times you'll be on what looks like a part of your quadricep. So we'll place the foam roller, down about here. And you'll just kind of press on that. Obviously, we're not rolling on the bone, but we're just looking for that rectus femoris. We're trying to get onto that origin. We're trying to loosen up that Golgi tendon organ right in here. Or sometimes you'll get like a knee, like a massage like right in here, although usually this is what's causing the tightness. So it is a hip flexor and a knee extensor. And that's also why if you want the world's greatest quadricep stretch, it's right here. So get a towel or a pillow or something nice and soft, and you are going to kneel on that, which you cannot see. I need a cameraman. So you're going to kneel on that like soft towel. And what I'm going to do is I'm going to take myself into hip extension. So I'm going to travel forward a little bit. So now my femur is being pulled posteriorly. So that's now I'm in hip extension, right? Hip flexion, my knee is up. Hip extension, my knee is pushing away. But what I'm not going to do is I'm not going to like arch like this, right? I'm just going to draw it into hip extension by leaning straight forward and keeping a neutral spine as I'm up. And then that's a hip flexor stretch. This is called a kneeling hip flexor stretch. I can also get a little bit of my hip flexors in my core by taking my arm up. But if I want to get my quadricep even further, I can then also go into knee flexion. So now I'm in knee flexion and I'm in hip extension simultaneously. And I'm going to get a great stretch right in that rectus femoris. It's awesome, but it will expose the crap out of your kneecap and grind it into the floor. So do it with a towel or do it with a pad or do it with something soft. Take your gym mat, roll it up a couple times. Don't do that one without plenty of padding. If you can't do that stretch, by the way, if you have a hard time like balancing, you feel like you're falling over, what you can do instead, and this is going to be a little too high because it's my full bed, but you can also just take your foot up onto a bench and then go down like that and lean forward. Like, actually, that's a pretty good stretch. Go like this. Again, put a pad under the knee. So that is a super, super awesome rectus femoris stretch. So hip flexor and knee extender. Next one we got that is also a little bit of part of your knee here. Now, it's not really in charge of too much knee stuff, but I put it on the knee day. We'll talk more about these two muscles when we get to the hip complex, but they are knee stabilizers. So they're there to create stability, which, you know, they need to be part of the conversation. So your gracilis is actually part of your hip adductor complex, but it also does assist in weak hip flexion. So this can be part of the hip flexor complex here. And it does internal rotation, right, of the hip. But it also assists in tibial internal rotation. So it is doing hip internal rotation and tibial internal rotation. So how do you stretch your gracilis? Well, again, it's in charge of internal. So what we need to do to stretch it is go external. So if you've ever seen, like it's a classic like dancer stretch, and I'm gonna butcher it, but it's where you take your leg up like this, and then what you do is you actually keep your foot facing this way, so it's facing straight up. So that's, if you look at when my hips are facing forwards, I'm in external rotation with this hip. I can actually already feel it. I'm in external rotation here, right? And then I would go into hip extension instead of hip flexion by leaning straight forward like this. So by doing a little like lean like that, I'm going to get a deep gracilis stretch right here. And that's a knee stabilizer, right? And if it gets overactive, that can cause tibial internal rotation. So knees caving in, that can be another effective stretch that can help with that. And then the longest muscle in your entire body, this is your sartorius. Longest muscle you've got. And it is going to run from the ASIS, so already you know it's going to be a hip flexor. And it's going to run all the way down and insert to the same spot as the gracilis there. So it actually crosses all the way over. This thing's like a freaking whip. It's hugely long. So it's in charge of, again, hip flexion. But this one actually does external rotation of the hip. So where before we saw internal rotation because it was tying from in to in, this one's going from in to out. So when it pulls your hip externally. And it also actually pulls into abduction, which is kind of surprising considering where it attaches, but it does do a little bit of this. But its main, you know, and it does assist a little bit in that internal rotation there. So your sartorius, it's another hip flexor. And so the reason we talked about the gracilis and the sartorius here is because both of these are there to stabilize your knee. Although we will spend much more time talking about them tomorrow when we get into the lumbopelvic hip complex. So that's really where they, you know, kind of actually belong. All right, so reviewing our motions, right? Reviewing our motions, gracilis, sartorius, right? You have got knee flexion and you've got knee extension. So those are movements at the joint, right? Flexion, you know, the angle is going from 180 degrees to now it's at 90 degrees. So the angle decreased. This is knee flexion. The angle increased from 90 back to 180. That would be knee extension. So, and that is happening in the sagittal plane. So knee flexion, knee extension. The hamstrings are in charge of flexion. The quadriceps are in charge of extension. Then you've got external tibial rotation and internal tibial rotation. And both of these can only occur if there's about 20 degrees. You have to have like about 20 degrees of knee flexion before it can happen. And so when you turn your foot away, that's tibial external rotation. When you turn your foot inward, that's tibial internal rotation. So I know that, and here's the thing that often confuses people. I don't know if anybody's already like, if this has crossed your mind, you might be like, wait. Tibial external rotation, but the knees are caving in. Wouldn't in be internal? No, because when you look at knees cave in, actually, that picture was great. That was intense. Who is this? Look at that demo. Good God. So see how like the knees are caving in? That is an external, it's external in terms of its relationship with the rest of the bone, right? So this bone is here, but now this is externally rotated. So we're seeing feet flatten, tibial external rotation, knee adduction, femoral internal rotation. So because the femur is internal, the tibia is external, and that's why that's why that is, you know, the way that is. I know sometimes that gets confusing, because that is what your biceps femoris does. It does tibial external rotation, which causes the knees to cave in. So there's your external, there's your internal. Medial hamstring is in charge of this. Lateral hamstring is in charge of this. Biceps femoris, medial hamstring. And let's go ahead and take a look at that, right? So our agonists for all of these specific joint actions, you have got, for knee extension movements, that's going to be your 3 vasti muscles and your rectus femoris. So here is your rectus femoris. It's running from the hip just below the ASIS down and inserting. And I love this picture because it actually shows the insertion going all the way to the tibia. Runs down over, you know, grabs the kneecap and then runs further down and grabs the tibia. And that's why it can do knee extension and hip flexion. And then you have the vastus lateralis, right? On the lateral aspect there. Then you get your vastus intermedius, which is in the middle, and your vastus medialis oblique, which is on the inside. This, by the way, the vastus medialis oblique, that's what gives you the teardrop. If you're trying to get that like nice little quadricep bulge, that's the one, you know, I'm not much of a bodybuilder, but that's the one that I got. That's the one that I can kind of show off. If I were to go to a bodybuilding competition, they'd be like, that guy gets 0 points for upper body, but he's got a good BMO. So there you go. That's your knee extension. Then you get your knee flexion. These are your hamstring muscles, right? Like I said, there are technically 3. It's 3, but you got to memorize 4 things. So you get your biceps femoris. Here's the long head. It's the longer of the 2, right? It runs from the hip and onto the fibula there. And then your short head starts on the femur and runs to your fibula. So that's the biceps femoris long head. That's the biceps femoris short head. The long head can assist in hip extension, but the short head can only do the knee flexion part. Whereas the long head can do knee flexion and hip extension. The short head can only do knee extension. And then both of them do tibial external rotation, which is bad. Then we've got our semimembranosus, which is here, and semitendinosus, which is here. And that's running from, you know, the same spot, but it inserts on the inside of the thigh instead of the outside. So that is from, you know, from the knee extension standpoint, you've got your quads. From the knee flexion standpoint, you've got your hamstrings. Then from the tibial internal rotation, if it's internal, right, so that would bring your toes this way. That is going to be your membranosus and your tendinosus. So those 2 hamstring muscles there. By the way, there's one that we didn't mention, a little tiny short muscle here called your popliteus. That's a little tiny itty bitty short muscle that runs and acts as like a little stabilizer back there. Never gets any love. Doesn't get injured very often, doesn't cause too much drama, so nobody ever talks about it. But that's your popliteus. I don't know why that's in this PowerPoint. You've got your external rotator, which is that biceps femoris, both long head and short head. So that's back there, doing the external rotation that we hate so much. So bad, so not what we're aiming for. And that's it, guys. That's the knee. That's the knee joint in a nutshell. Hopefully we talked enough about squatting and sort of what the posture actually looks like to make that make sense. Yeah, how's everybody feeling? Nicholas, Noel, Robert, how you guys feel?
Pretty good.
Not too bad?
A lot of information though, you know.
I know. I told you the list was short yesterday, but it gets bigger. I think the biggest I can't remember if the shoulder or the lumbopelvic hip complex is the largest. Either tomorrow or Monday are going to be the long ones.
Yeah. So when are we gonna take the quiz? I mean, not the quiz, but the big one.
The final, that is going to be. So let's see. We got tomorrow. Monday will be homework, and then Wednesday.
Wednesday. Okay.
Yep. So make sure you get homework. We're going to have homework 3 is going to go out today. So that's going to be 15 questions about the knee joint and the ankle joint. Knock that out as fast as you can. Start practicing it every day. I saw that you did a great job practicing your homeworks, by the way. You've got like a funky percentage score. You got like a funky decimal, which makes me know that you practiced. So normally, like you miss 1, you get 93%. You miss 2, you get 87%. You miss 3, you get 80%. But when you take it twice and you get averaged out of 2 scores, you get like a 95.1, you know, like you get like these weird numbers. That's how I can tell like people who are like taking it over and over and over again. You don't have to take it over and over again, but why wouldn't you? It's practice, you know?
Right. But my question is, can you use the 2 quizzes to make notes? The quizzes, the homework.
That's
1, 2, and 3.
That's why I always send you in the email and I put links. That's why you can download your homeworks. I've had students who make, I had this one lady who was like super organized. She's like ex-military, so she was like just organized to a T. And she had like a 3-ring binder where she took all of her notes from like the entire core, and all of them were in there. And she would do her notes. They looked the same way class looked, where it was like, you know, day 1 notes, day 2 notes, plus homework 2. And then the next page would be day 3 notes, day 4 notes, and then homework 2. And like it went in order. So she had all of her homeworks like in this 3-ring binder. And that way, like, you know, she could be like, man, I'm gonna go take my test, but I'm really nervous about, I don't know, make something up, say nutrition, right? So she could flip to her nutrition notes and just like study through them. So yeah, you are totally welcome to keep your homeworks forever, print them out yourself. We'll print them for you. Practice them over and over and over again. Use them as your notes, you know?
Is it open book though? The test.
The homeworks are open book. The test is closed. Because we're trying to also prepare you to take the real NASM. When you go to take your actual NASM test, you're not allowed to have your phone. You're not allowed to bring your keys. You have to bring your driver's license, but then you have to leave it at the front desk. Like they make you walk in there, you know, with nothing, and you have to sit at this little cubicle, and there's like a camera that's above you that makes sure that you're not like pulling stuff out of your pocket. So because we want to prepare you for a situation like that, you're not allowed to use your notes on the tests. But you're totally allowed to use them on your homeworks. But yeah, any other questions?
Yeah, I got one more.
Yeah, let's do it. You know me.
Hey, we had that outside. We had to go outside, right? We meet outside at the park.
Yeah.
Did we now we missed a day. Do it? Is it attendance are you taking?
So
or is it questionable optional?
Yeah, so those attendance days are optional because like I don't want to make any, you know, I know some people are still taking the quarantine super seriously. And I applaud that. That's fine. So, you know, if you are super nervous about it, I'm never going to make the in-person until we get back to real Sochi. Like once class starts, it's like, yeah, you need to be in class every day. You know, like once we get back and like all of this crap is over with, then attendance is mandatory. But like when I do these small little workshops, I'm not going to make them mandatory. Also because like, I don't think it's fair to, you guys have to travel to a place that's not Sochi. Like when you signed up for Sochi, you're probably, you might have looked at bus lines and you might have been like, okay, I can get there. I'm not gonna, meet in a place that's not Sochi and make that mandatory. Although I will look at like your attendance before and your attendance after. So like if you're missing class consistently, and then you don't show up to like that workshop, like that's just another day of missed class. You know what I mean? That's kind of why we started doing it on our test days, because like as long as you get your homework into me, I can give you full attendance without feeling guilty. Right. And that way it's fair for everybody. But yeah, Noel, if you're worried about like getting there, don't sweat it.
Oh, okay. I was worried that day.
Yeah, and it'll never be, the workshops will also never be something that I don't at least talk about on the calls. It'll also never be content that isn't at least discussed, I don't get me wrong, I think it does give you an advantage, but not from like a score standpoint. But yeah, anything else? Any other questions? I love these. Nothing about the biceps femoris?
Do we have to memorize what muscles sit in front of other ones too? Like the actual positions? Like
deep versus superficial?
Yeah.
No, I didn't even teach you those terms. So no, yeah, you don't need to know that.
Because I know like the vastus lateral or the vastus intermedial.
Intermedius, yeah.
That one, does it sit in front or behind?
Behind.
It sits behind
the rectus femoris is the one you can kind of poke. Yeah, you don't have to do that. This isn't like a traditional kinesiology class. You'll get like a million questions that are like, which is deep, which is superficial, and it's all about like their locations, like where does it originate, where does it insert. We don't do it that way because NASM doesn't test it that way. I think that it's helpful. Like I'll talk about it. I want to talk about where something originates and where something inserts, so that you understand like where the muscle's running, and then it kind of gives you a visual for why it pulls the way it pulls. And I think that is handy info, but we're not going to test you on that. You're just going to get tested on their function. As like a personal trainer versus like as a personal trainer, not as a kinesiologist, we're concerned about how people move during exercise or how they move during their posture, right? We're not surgeons. We're not going to have to go digging around and go straight to a muscle, So yeah, you don't have to worry about that. All right, guys. Well, I'm going to go ahead and end today's call, and I'll see you guys for the lumbopelvic hip. We get into the booty work tomorrow. We get to the glute city. So that'll be a big one tomorrow. No pun intended. All right. See you later, guys.